Welcome, everybody. Folks, let's jump into episode 4 of Rising Stars in Ophthalmology. And we're going to take a look at a very special topic called the clinical challenges in cataract surgery. But before we do that, I'd just like to explain how all of this works. You see the people on your screen today. We have one rising star and surrounding her with watched on our website because this is a global event and the timings may not match sometimes. Also, watch out for our social media, Facebook, Twitter, LinkedIn, Instagram, because we do have some really cool educational tips that come out from all of these episodes in small snippets. I'd like to thank each of you for tuning in and thank you for all the sponsors to make this happen. And now to do the honors, I want to call upon Bill Trattler to introduce the speaker and the celebrity panelists. Thank you.
Thank you, Asha. I'm just going to share my screen and get things started here. Okay, so beautiful. Well, this is super exciting. Obviously, this is our episode 4, and I'd love to...
Centro Oftalmológico de Minas Gerais. It's amazing.
Perfect. Thank you so much. And then I do love your fun fact, which is that Canabrava in Portuguese means people that drink alcohol a lot. And of course, I thought the fun fact is that you share that you don't drink alcohol, but it's funny that your last name is is that. So we're super honored to have you. You're just one medicine. Performed his fellowship at Mooresfield Eye Hospital in England, and he had he spent time with 3 mentors in the USA. He's currently the professor, professor in Alan Mosbacher and law chair in ophthalmology at Baylor. And Doug, what a fun fact. Do you want to just share your fun facts?
Yeah, it was kind of crazy. I was already ready to go into pediatrics, and I took an ophthalmology residency and said, oh my gosh, this is what I want to do. And in my 3rd year of residency, I was already programmed and had a great pediatric ophthalmology fellowship. And one of my colleagues said, we need someone to do anterior segment surgery here. And I made a switch like that. So serendipity really played a big part in my whole career path.
Yes, we're so lucky. We're so lucky that you made some good choices and went in the right direction, so we could be here all together today. And of course, this is Dr. Ann Zaki. We're so honored to have you as well here. You went to medical school at George Washington University School of Medicine. You did your residency at Boston University, and then your fellowship. I've seen that name, Baylor College of Medicine. Who is your mentor?
None other than Dr. Douglas Koch.
Perfect. And Doug, you've trained so many amazing people. Dr. Zaki, we're so happy to have you. I know you're a partner at Desert Eye Specialists and you're assistant clinical professor of ophthalmology at the University of Arizona College of Medicine in Phoenix.
I'm Egyptian, born to Egyptian parents, of course. My parents have incredible names, Isis and Ramses, and they named me Anne. I have 2 kids, 12 and 14.
Yeah, I love it. Yeah, that's so great. So beautiful. And Celebrity fans, we're happy to have you because we're here to celebrate our rising star, Dr. Nicole. And Nikki, if you could just pronounce your name for everybody. So I don't want to, I know I could probably get it, but I just love
Bajic.
Yes, exactly. So it's like like you're buying something and then you have a little bit of an itch. Is that correct?
Yep.
Okay, perfect. I love it. And so you're so nice to share some incredible photos. And do you just want to share this photo and what the details of this?
So I'd be remiss if I didn't explain, how I got here, if I didn't thank my mother, because she's the reason why I'm here. She's the little girl in that photo, and she was actually born in a very small rural village in Croatia, and her family, was destitute and were not able to take care of her. So they were actually forced to give her away to be raised by her aunt and uncle. And she dreamed big despite her circumstances, made her way to America. She got a full ride to nursing school and actually scrubbed for cataract cases. And so, if that little girl didn't dream big, I wouldn't be here today.
Oh yeah, I love it. Thank you so much for sharing this very special photo. Let's see if we can get to the next one. So this is, I love how you just titled this, your origin story. I guess you're born in Chicago. Do you want to share this? Why don't you share the details here? It's best if you share it.
Sure. So I did my undergrad in medical school at Loyola and residency at University of Chicago. And then I was also an AAO advocacy ambassador during my last year of residency as well.
I love it. And share the photos, the details.
So the first one is where I am an advocacy ambassador. So it spurred my interest in advocacy. And then below that, I'm with Dr. Marian Maxey, who was a mentor for me during residency. And then the one below, it's at my graduation with Dr. Catherine Colby and Dr. Peter Veldman.
Oh, beautiful. And then I guess share some details of your post-residency.
Yes. So I went straight from residency to my first job. I was in private practice in the Chicago suburbs. And a fun fact about that is, so the woman who owned that practice, she's up in that picture, that first picture with me, Dr. Mona Toms. She was actually a resident in training when my mom scrubbed for her when she was in training while she was pregnant with me. And when my mother delivered, she and the rest of the ophthalmology residents brought me a little baby me, a teddy bear. So she gave me my first teddy bear and my first job.
Oh my God, that's amazing. That is amazing.
Yeah. And then while I was in Illinois, I was also on the board of directors for the Illinois Society of Eye Physicians and Surgeons. And then in fall of 2020, I transitioned to work at Koch Eye Institute in Cleveland Clinic. And I am continuing my work in advocacy. I'm currently on the board of directors for the Ohio Ophthalmological Society, as well as the District 5 governor.
Oh, beautiful. Excellent. Excellent. We have some more fun photos. So if you could share these.
Yes. So I'm married to my husband, Peter, who practices as a urologist and sexual medicine specialist also at Cleveland Clinic. And we have a beautiful 9-month-old daughter, Sophia. And then our dog, we adopted him in Chicago, Gus. Legend has it that he was found as a stray eating tacos in the Pilsen neighborhood of Chicago.
Oh, that's so great. And then I love this little series of photos that you have.
Yes. So a little bit about our personal interests. So we love to travel. We love to cook. And then I also love to teach my old dog new tricks. So I'm asking my dog, Gus, who's the most handsome. And he does
That's
it on
awesome.
cue.
So beautiful, beautiful. Well, thank you so much. And we're so happy to have you here. And I'm going to turn it over to you so you can share your screen and kick things off with your presentation.
Fantastic. Okay. Well, first off, I just wanted to thank everyone for the incredible opportunity. It's such a humbling honor, and I'm so grateful for it, especially to be among such esteemed colleagues. So thank you so much. So today I'm going to share a few clinical challenges in cataract surgery. You know, when I go to conferences, the cases that really stick with me are, you know, the very interesting challenges where the surgeon typically says it shaved a few years off their life, or, you know, perhaps like the more odd cases that someone collects. And I also have a case or two where, you know, it's a common challenge that you might come across during cataract surgery, but doing the classic approach you're trained to do doesn't seem to work out. So how do you adjust and maneuver around that? These are my disclosures. So for case one, this was a 37-year-old male who was a computer programmer, an avid golfer, who had unilateral insidious loss of vision in the left eye over 6 months. Vision in the right eye was 20/20 and in the left 20/70. Pupils, pressure, motility, and visual field were normal. This was his current glasses prescription. And then in his manifest prescription, you'll see that he had a huge myopic shift. But interesting to note, there was no significant increase in cylinder. And then the best corrected vision we got was 20/50. Interestingly, the slit lamp exam and the dilated fundus exam was pretty normal. The only finding was just a very trace opalescence of the lens in that left eye. It did not look like a 20/50 cataract. So my first question for Dr. Koch, what test or technique do you do next at this point?
I have a cat who's meowing loud, so I have to mute in between. You know, in this situation, when somebody has a myopic shift, even though you call it trace opalescence, it can be very deceiving. It can actually be a lot more significant. So the first thing I do is actually pick up a retinoscope. And with retinoscopy, you can often detect the very small central nuclear opacity, which is really less an opacity than a refractive change in the center of the lens. And of course, you do all the other things. You do corneal topography, you do macro CT, and do your biometry, just look at axial lengths. But presumably, this is a deceptively more important or visually significant cataract than the appearance would suggest.
Very good. So I use the long lost art of retinoscopy, and you see this is the right eye, normal red reflex, and the left eye, you can see there's an oil droplet cataract. So with your interest in pediatric ophthalmology, we had a surprise oil droplet cataract in a 37-year-old. So there are many surgical considerations with this particular case. We have a 37-year-old who's not yet presbyopic, yet has a unilateral cataract. He's also a low myope, and then he has a highly astute, very discriminating personality. He's a computer programmer, so he needs good intermediate vision, but also an avid golfer, so he wants excellent distance vision. So my next question is for Dr. Zaki. What type of IOL and what target would you choose?
Well, after a long discussion with the patient, you could consider a few options. Naturally, with some of our enhanced depth of focus lenses, that would be a good option where he could get distance and good intermediate vision, obviously addressing the astigmatism. The other thing you could consider is, if the patient could tolerate some sort of monovision or a modified monovision where you could target a little bit more on the near to still give them enhanced depth. But that's more than likely, after talking to him and understanding his needs, that's more than likely the direction I would go.
Very good. So after a long discussion with the patient about what their goals were, we actually elected for an extended depth of focus lens, and we elected for Avivity. So at our institution, we do bundle our multifocals with femtosecond laser. And so I brought up the nucleus and I'm just chopping it here. I wasn't sure with the, acute progression of the myopia, if there would be any focal thinning of the posterior capsule. So I just wanted to get the lens out as much as possible. And here I'm just cleaning things up. And as classically with our femtosecond cases, the cortex was a bit gummier. I polished, and then now I'm putting in the lens. So I wasn't sure if it would be more prone to decentration. And so I did like the idea of Avivity because I felt, it's a very forgiving lens. And there we go. So our outcome, he ended up thrilled. His vision was 20/15 uncorrected, and he ended up J2 at near, and he stopped wearing glasses altogether. So, it's interesting that you had brought up monovision. He's actually, already kind of monovision. His spherical equivalence -175, so it's perfect. And I feel really good about this because this is going to carry him through the presbyopic years, and he may even elect to stay this way. But he's thrilled with the final outcome. And I love this case for so many reasons. One, because this is an exceptionally rare type of cataract, and it usually happens in the pediatric population. But as rare as a cataract that it is, it's even rarer to be able to diagnose it promptly. And my patient had actually came to me at our final post-op visit, and he had said that he found a message board online with, a whole bunch of other patients who also had oil droplet cataracts. And he had been reading about their accounts and how they had, some of them work up for years with, extensive imaging, MRIs, and very frustrated about the process. And he was astounded because he said, you diagnosed it on the very first visit. So it was very exciting. Most, patients do end up going to neuro-ophthalmology or retina specialists, and, you can get considerable costs. An ERG and MRI, that's his multifocal right there, but retinoscopy is free. And so I point that out because it's a simple thing that you can just do to check in the office. And then if you get it, it makes you look really slick too. So question for Dr. Canabrava, any additional thoughts here?
Hello, Nicole. Great case. This retinoscope is a good information for the audience that watch here. I think the Vivity is a good option for this patient. Another option that you can think, like Anne told you, like to use a monofocal in this eye, a spheric IOL, because this patient there is a myopia in the another eye. And maybe it can have a good option for this patient too. But I agree with you. The Vivity is a good option in this case.
Very good. Thank you. Okay, so case 2. This was a 66-year-old binocular male with a unilateral cataract in that right eye. And it's hard to tell at this angle, but it was a quite dense cataract. And this is a picture of him post-dilation. He had a history of complicated cataract surgery about 30 years prior. He was left aphakic and he developed retinal detachment subsequently as well. And also, I should mention that he had nystagmus, to just throw another curveball into the mix. And so you can see there that there's an anterior polar cataract with the iatrogenic capsular rupture. He had denied any prior trauma, and there was no corneal scarring to suggest otherwise. So, question to Dr. Canabrava, what are your thoughts on this cataract?
This case is the case that I love it. In my opinion, if the patient don't have a good dilatation with adrenaline, it's important to use iris expansion ring. I prefer to use iris expansion ring that's iris hook. And how the cataract, the polar cataract is the anterior chamber. I think it will be good during the fake emulsification. You need to pay attention during the rexis, but I believe in you. You conduct this case amazing.
I wouldn't share it if it didn't turn out okay.
We've got a question from the audience in the previous case. Why not a multifocal and why Vivity? I mean, it's a question.
Sure.
I think it's.
So I'll
and anybody can take that. Yeah.
I'll jump in with mine, and then any of the panelists who want to expand on it. So for me, you know, I really wanted to make sure I listened to the patient so that he was satisfied. I think that's number one, the most important thing. Because he was a very discriminating type of personality, right? And so, you know, I hesitate in those personality types, especially low myopes. They can be dissatisfied by maybe a little bit loss of the crispness that, you know, you can get, right? You know, with multifocals, there's a compromise, you know, with the extended range of vision, you know, you can have a compromise in the quality. It's mild, but, you know, some people are more sensitive to others. The hyperopes, you know, they classically do really well with it, but, you know, low myopes, they can be sometimes, you know, pretty dissatisfied depending on the personality type. And for him, in my gut, I just didn't think it was a good option for him. So I like the Vivity because I felt like I was getting the best of both worlds, and he was very satisfied with it.
I'll jump in. I think Nicole said it very well. You know, his goals, probably considering his work and his hobbies, are distance and intermediate. So going to an EDOF makes sense. I would have considered also the New Symphony Optic Blue in this sort of setting as well, just because the quality of the distance vision, I think, is the best among the EDOFs, as well as the intermediate. But it does create glare, and you really have to feel him out for his his ability to tolerate that. And that's really the strength of the Vivity, which is the glare profile. So excellent in that lens.
Gotcha. Thank you, folks.
So to jump back in case 2, for surgical considerations, you know, this patient is functionally monocular. So I knew that this second eye may be quite a challenge. You know, and the patient was left aphakic and developed a retinal detachment. So I wanted to make sure I took all proper precautions possible. He was also a poor dilator, and then a dense cataract with an anterior polar, and had an iatrogenic capsular rupture. So we know that the capsule is abnormal here. So panelist question for Dr. Zaki. How would you approach this case?
So naturally, there's a number of things, a number of obstacles you kind of have to get through. Knowing that he was complex before, knowing that he's monocular, naturally, with every case that we do, we take that always into consideration with our patient status. And, we want to approach this very carefully. So as a port dilator, I think my number one approach, typically I'll use a Malyugin ring with everything, but in this case, just being with the capsule, what it is, I want a little bit more versatility. So I would actually use iris hooks to dilate. I would also, as I approach this, I would use trypan because I'd want to know exactly what that anterior capsule looks like, if there, where and how does this anterior or the capsular rupture extend. And naturally, when I go in, you have to just take every step very carefully because, as we know with cataract surgery, one step builds on another. So wound construct as you're entering, very, very important. So you have stability of an anterior chamber, careful not to overfill. My parameters on my phaco machine, again, would be slow and steady. My vacuum would be low. My bottle height would be low. And just slow and steady, I think, wins the race every time.
Absolutely. You read my mind. Great minds think alike. So, with nystagmus, the anesthesia can dampen it significantly, but I did a block as well. And then I did elect for iris hooks here because I also wanted to use trypan. And you can do iris hooks before any OVD because they're much more gentle on the capsule. So that allows for you to do the trypan. And then I actually put in Helon here to help keep the capsule from hopefully running out. I attempted a needle decompression. I don't think it really added much. And then I started the rhexis adjacent to the rupture. And if you see, I'm keeping this on a very, very short leash because I know that the capsule is abnormal, so I don't want it to run out. Because I also wanted to make the rhexis a little bit larger, knowing that this was a very big, dense cataract. I wanted to get it out of the bag because it was going to be one of those really leathery, dense ones. And I wanted to do a fair amount of chopping. So here I am bringing up the lens. And as I suspected, it's a very dense, leathery one, which you can appreciate there. I also didn't know the status of the zonules. As I wasn't able to check for phacodenesis. So I like the idea of getting the lens out of the bag to avoid additional zonular stress. And we get the bulk of the lens out, and now I'm just cleaning up cortex. Get a one piece in the bag. And now I'm just cleaning up. And we are home free. So happily ever after, much different than the first dive, fortunately for us. So for key takeaways, if you have nystagmus, light sedation usually does the trick, but if you want something more, you can always do a block. It's especially helpful if you think that the case might be more complex. And then if visualization of the capsule is needed, but the patient's a poor dilator, I actually really like using iris hooks prior because you can do it before any viscoelastic. You can also consider needle decompression. That didn't really help in this case. I think that it already self-decompressed with that iatrogenic rupture. And then you can start the rhexis adjacent to the anterior capsule rupture. And keep in mind that this capsule is abnormal and may try to run out. I did use Helon for this case. It may have provided some benefit, and just keep it on a short tether. So, question for Dr. Koch. Any additional thoughts on this case?
Beautifully handled, Nicole. Really nice. I think the only things that my additional thoughts would be too, I normally use Malyugin rings for my small pupils, but when I have a case like this where I'm uncertain about zonular status and other aspects of it because of the capsular break in the anterior capsule, I like hooks because I can adjust the pupil size intraoperatively if I need to make that larger in order to do things like segments and so on. So I think that's really the right choice. And usually when I see a capsular rupture, an anterior capsular rupture, I actually start my capsulotomy well away from it. I'm just going to go around it. I just don't want to get involved with it because I'm afraid it might have some tear forces that might lead one astray. And once you did actually go peripheral to it, you did a great job. And I love the way you picked it up several times along the way. You had perfect control of that capsulotomy.
Thank you. Great. So moving on to case 3. So this was a 65-year-old white female with metastatic breast cancer who was referred for cataract surgery. And I have access to the last exam, and it noted a 2+ NS with cortical and 3+ central PSC. The patient asks, do I have to get dilated again? I really don't want to. I mention this because I have heard some colleagues, say that, when they get a referral for a cataract, that they frequently may not repeat dilation. They'll rely on someone else's exam. However, for me, myself, I think that it's really important to trust, but also verify. And I'm really glad it did, because in this case, it totally changed my management. And I revealed a dense posterior polar cataract. So, question for Dr. Canabrava, any pearls or for surgery with the posterior polar cataract?
Now the things change because now in the posterior. The first point that I always discuss with the patients is to discuss about vitrectomy in this kind of case. So all patients that I have cataract, I tell him, so all my patients with this posterior polar cataract, I present for the retinal surgeon that work with me. And so, of course, the hydrodelineation, and I like to hydroprolapse. You need to go so slowly in the nucleus goes down. Now now, Nicole.
Great. Well, thank you so much. So yes, as you mentioned, the thing that we all classically learn, and especially for boards, is that you have to hydrodelineate. However, then what? And what if the hydrodelineation doesn't work to free up that endonucleus for you? So this is the case. So I think it's really important when you're starting off, the first thing to keep in mind is, given the high vitrectomy rate, you'll want to aim for that 5 millimeter rhexis, because you want to have good anterior capsular support if you do need to put in a sulcus lens. And then, opinions differ on this, but I do like to release extra viscoelastic, at least to decrease pressure in the AC. And so I then did hydrodelineation, or attempted to, but I'm not seeing a golden ring. And I suspect because this was a dense cataract with a heavy cortical component, but it looked like that endonucleus was mobile. So I continue to move on, but I can't get that endonucleus up. So I pivot and I use my chopper to actually manually dissect that endonucleus to help bring it up. And finally, with this last go, I'm able to bring it up. And then from here, I'm able to bisect the nucleus and bring it up out of the bag. And then I finish chopping from here. The patient started getting a little squirrely by this point. So you normally don't want the AC to collapse, but I knew the patient was going to cough. And so I got the instruments out. Fortunately, there was enough of the cataract still in the bag that it was able to keep everything back. And so we didn't have an issue there. And so I have this nice thick epinuclear shell, so that's very protective. And we're just finishing phaco with that endonucleus. And now at this point, I'm going in while I still have irrigation, and I'm viscodissecting all 4 quadrants of that epinuclear shell. This viscodissection is much more gentle than hydrodissection, and so you're able to remove that shell in a much more controlled way. Also, if there is a break in that posterior capsule, or sometimes the posterior capsule and these posterior polars are totally absent, so you can tamponade it with the visco. I was concerned that there might be a defect there because it looked like there was a little brighter spot in the red reflex, but fortunately, we are good. I'm just getting the rest of the epinuclear shell out here. And one thing I want to mention is, once you're getting this point out, you might see a little something where that posterior polar was. It might be very tempting to polish it. Do not polish it. That capsule is not normal. And very frequently, you'll have a break when you go to polish it. Also, there was a little bit of cortex I wasn't able to easily get out. So I actually elected to So surgical considerations for posterior polar, these have a very high vitrectomy rate, about 26%. And so things to keep in mind, aim for a 5 millimeter rexus, hydrodelineate, and you can viscodissect the remaining epinuclear shell, and don't let the AC collapse because that's going to help keep the vitreous back, and you can use visco to help tamponade as well. And then do not polish the posterior capsule, as tempting as it may be. And then obviously hydrodelineation is the big key that we always hammer home. However, it can be really difficult sometimes in these really dense cataracts. And so if need be, you can use mechanical separation to help get the rest of that endonucleus out. Okay, so Dr. Zaki, any thoughts on this case?
I think you handled that beautifully, Nicole. One thing I always like to, talk about as well is even, if you have cortical remnants, what you did with the remaining cortex was fantastic by putting the lens in, protecting the bag. And sometimes just if you kind of gently rotate the lens a little bit, it'll loosen up that cortex just like you did. If you have some remaining cortex in the context of posterior polar cataract, I'm always very careful. I use bimanual INA to remove the cortical fragment or the cortical remnants. And I always kind of pull from the outside in very gently as to not, disrupt the capsule if it is weakened in that area. So I really love bimanual INA in this kind of context or any time where I think I might have a weakened capsule.
Great. That's a great tip. Thank you so much.
Nicole?
Okay. Uh-huh.
I might just jump in and say I do it a little differently with posterior polars. I was on that paper with Bob Osher, that very first one. And fortunately, I think the incidence is much lower than 26%. But what I like to do is do a stop and shop and just sculpt and break it into 2 halves. And then if it doesn't rotate, I can viscodissect each half into the center. Just another way to kind of handle that problem that you are so true that you can't always hydrodelineate and get it mobile. This is just another way to do it.
That's a fantastic tip. Thank you so much.
Question from the audience. Sorry. Why not use a pre-chopper in this case? I mean, it's just, yeah.
Why not use a
pre-chopper? The Akahoshi pre-chopper. I mean, that's just the name, but
yeah, you could. It creates some stress on the zonules, or on the capsule, maybe by the pressure you're having to push down, particularly with a dense lens to penetrate it. So that's why I'd rather sculpt it out in the center, or I like Nicole's way.
Perfect. I hope they're all getting that answer.
Another point you need to add here, Ashley and Nicole. The surgeon needs to do a good examination in the sleep lamp, because when the polar cataract goes after the capsule, the surgery will be totally different because there are more chance for the nucleus luxation. I like to say this: true polar posterior cataract and false polar posterior cataract. Sometimes the polar is only behind the capsule. So it's a good important point to do the examination in the sleep lamp before the surgery.
Very good. Thank you
Solid
so much.
point. Thanks, Sergio. Nicole, go ahead.
Great. And then so for my last case, so this is a case that I'm sharing not because this was a great catch or I had some heroic measure, something a slick maneuver, a challenging situation. This was just a very challenging case, and actually I had a very easy, simple solution at the time that I didn't know that I had, and it ended up being a more stressful course that fortunately ended up well. But I'd like to glean my panelists' pearls from this case, because I think this is a really important learning case if anyone watching this ever finds themselves in a similar situation. So this was my second year out in practice after training, and this was after the 8-week hiatus of elective cases during the pandemic. And it was the very first day back in the OR and the very first eye scheduled. The patient was an 85-year-old white female, was rescheduled for her second eye for cataract surgery. The first was fairly routine. It was 3+ NS with 3+ cortical. I used Trypan for that case as well, and she did well. Unfortunately, this ASC did not have video recording capabilities, but I think that this case is really important. And so I have this terrible budget reenactment, but I think it's worth it for the discussion and learning points. So I had started off the case with Trypan, and the scrub nurse that I was with, I think she was a little nervous with the pandemic and being back around people. And we had dropped the BSS cannula. And of course, we didn't have any backups in the room. And so she had ran out of the room to get a backup. So the Trypan had been in there for maybe about a minute at this point. So I go to irrigate it out. And I'm proceeding with the rest of the case. And I can't help but notice that I feel like the cornea was starting to look a little bit cloudy already. But, obviously the view is fine enough. So I continue ahead with the case. And as I progress with the rest of the case, it still looks like it's getting cloudier and cloudier to me. But again, I had a good enough view, so I continue to proceed. And eventually it started to get very cloudy. Oh, it looks like the case mid-procedure because I lost my view and was not able to proceed. So I had intraoperative corneal decompensation, and I have zero idea why. I thought maybe it could be the Trypan. For full disclosure, this particular ASC had an issue with their Trypan 2 years earlier. They had 10 cases of TAS that they had figured out was from their Trypan. Also, could have been due to possibly some cleaning agents. This was our first day back after, the COVID pause, and people were, more aggressive with cleaning. We also were using reusable cannulas as well. And then lastly, I thought maybe this could have been due to Decimase tear. I didn't see one, but it's always possible. Also, it appears to be getting progressively worse. and the lens is now exposed. So panelist question to Dr. Zaki, what would you do?
Well, this is a very tough situation because naturally you're in the thick of it at this point. So with the increasing corneal decompensation, the question is, where is this coming from? One thing when sometimes that, as a cornea surgeon, as things are pretty hazy, sometimes I'll remove, the epithelium to see if that gives me a better view as to what's going on. Naturally, it seems like this is kind of changing right in front of your eyes. So I don't know if that would have helped. Another approach would be to have a light pipe or some other device that is kind of tangential to the cornea to give you a better view as to what's going on intraocularly, because sometimes as it decompensates, it's just harder to see. So to be able to use a different light source to better visualize, naturally you have to finish the case, because with the lens exposed, you can't really leave it. So, there's no turning back at this point. So visualization is key, but that would more than likely, at least that's where I would start.
Yeah. No, so I think that's fantastic. I really wish that I de-epithelialized the cornea. I wish I had thought of that. But in the thick of things, I tried everything else. So I requested glycerin. Of course, they didn't have that. I gave IV mannitol, which of course that takes time to work anyways. I ended up giving 1,000 of Solumedrol. And then in a sad attempt to try literally everything I could think of, I was pouring Miro on the cornea. And unsurprisingly, nothing changed acutely, right? So I brought her back to clinic 2 hours later because I just wanted to reassess. I actually stopped the case because I didn't feel comfortable. I didn't want to potentially make things worse, and I needed to reassess things. So I put in a suture and saw her in clinic, and this is what she looked like at the end of the case. So this hadn't gotten any worse at this point, fortunately. And it also gave me the opportunity to do an anterior segment OCT, which this is the picture that kills me, because if you look at it, the edema, it's all anterior. I could have de-epithelialized the cornea and I probably would have been fine. So I share this case because I want everyone watching this, if this ever happens to you, please try that first. It could make things a lot easier for you. But yes, I confirmed there was no Descemet's tear. So now what do I do, right? I have an eye that's open, the lens is exposed. I phoned a few local cornea colleagues because still at this time, I wasn't sure. And I had some various thoughts and ideas. Again, this was a peculiar time because this was in the midst of the pandemic. But what's interesting is I had a very wide array of thoughts and ideas here, namely, that they needed either an urgent PKP or that we needed retina to remove the lens pars plana. And then finally that, if you put the patient on high dose steroids, Miro, and watch the pressure, you'll be fine to go back in a few days. So Dr. Koch, if you're at this point, what do you do?
Well, this is obviously a really wicked situation. If I were to guess what happened, my guess would be that when she dropped the cannula or the BSS, she got another cannula. She gave you a syringe with water or some other substance, that you were inadvertently given something that wasn't the right solution. Because you noted it so early in the case, Nicole, that and none of those other things you mentioned happen that quickly. You don't get tasked right away, et cetera. So if that is the case, that endothelium could recover, but it could also be destroyed. I do think you have some time. I don't think you have to go back right away. Control the inflammation, and kind of observe and see what happens to the cornea. Because the last thing you really want to do is have to do a PKP in this lady. If anything, you'd like to do a DMAC or a DSEC rather, and if that is what comes to, and then do the cataract surgery even a few days after that, after it clears up. So I would definitely take this slow. I wouldn't jump in right away, but I'm suspecting that endothelium, if it's going to recover, would do so in 3, 4, 5, 6 days, and then you can go back in.
Yeah, so excellent. I started the patient on 60 mgs of Pio-Pred Q-Day, had her on Muro and then Cosapt and Brimonidine. And by the next day, she was already looking better. And then on day 2, I was seeing iris details. And then on day 4, she cleared up beautifully. So I brought her back to the OR, got a lens in the bag, and she ended up 20/20 uncorrected. So fortunately ended up really well. But what's very interesting is that the posterior capsule was, it appeared very friable, almost a little bit wrinkly, but fortunately she's doing well. Everything ended up great. So my final question for Dr. Canabrava, any additional thoughts or different approaches?
God, no, I don't have not additional thoughts because I had never a case like this one. That's the case that I had was only epithelium problem. That with remove the epithelium, I could to continue the fake emulsification. But like your case, the first time I see.
Very good. And that's it. So I just wanted to thank everyone again so much. It's such a humbling opportunity, and I'm so appreciative. So I learned already so much from the celebrity panelists. So thank you so much, and for your attention.
Thank you, Nicole. This was brilliant. You've actually thrown all the celebrity panelists under the bus with all your cases, and
No!
and really brought out the best from them, which is what we really want from this series. Honestly speaking, it's been brilliant because the pearls that you spoke about and the cases that you have spoken about are so prominent and they're so actual in our day-to-day life. It's not a rare scenario, which is what people look at me for and say, what is this? You're showing me all these rare ones, which I don't get to see anyways. But your cases have been so prominent and relevant to so many people across the board. We really cherish to have this episode with you. And to all of you, Sergio, Anne, and Doug, you guys are just brilliant at what you're doing. Thank you for this episode. Some of these pearls are definitely coming out in our snippets, so we'll keep sending them to you as and when we make them. But to our audience, thank you so much. Please, if somebody has missed it or you want to reach out and tell where to watch this episode, it's on risingistars.com. It will be available in 48 hours from now. So we'll just snip off a little bit here and there and put it up on our website. Until next time, we're probably having our next episode next month. So until next time, thank you very much. And I'll see you guys soon. Bye-bye. Thank you.
Hi, guys.
Thank you.
Thank you.
Thank you so much. That's great.
Great job, Nicole.
Awesome.
Bye.
Thank you